Thank you so much. So Elliot, can I get started?
Yeah, you can get started. Go ahead.
Okay, so good afternoon, everyone. I'm Monica Aggarwal, Assistant Professor at the University of Toronto, and I want to welcome you to the Systems Planning session of the conference. I will be moderating this session for you today, and I will also be your first presenter. So I'll start with my project, which is about conceptualization and measurement of team collaboration, functioning, effectiveness, and performance in primary care. I'm presenting this on behalf of my team, which includes Celine Belzic, Sonali Roy, Ross Upshur, and Ivy Bergeau. And I just want to thank our sponsors, which include AFTO, the SGFP, and the Ontario College of Family Physicians. So as you know, interprofessional team-based care and ongoing performance measurement is the cornerstone of building high-performing primary care systems. But one of the things that I've noticed in looking at the literature is there often is lack of clarity in how you define and measure concepts like team functioning, collaboration, performance measurement, and effectiveness in primary care. And as a result, that poses significant challenges for evaluating team-based care. So our research questions were to look at how are these terms, team functioning, performance measurement, team functioning, performance, effectiveness, and collaboration conceptualized in the primary care literature? What are the different data collection instruments that are used to measure these concepts? And what are the measures of team functioning, performance, effectiveness, and collaboration? So we undertook a systematic scoping review using Arki and O'Malley's methodology, and it was a fairly comprehensive review that involved looking at 6 different databases. We also did a variety of gray literature searches and used snowballing techniques to identify literature. Based on our inclusion and exclusion criteria, we identified studies. We had actually 4 people working on this study because it ended up being such a large study. We extracted all the data from it, and then we did 2 types of analysis. We did a content analysis, which was really about analyzing the definitions and conceptualizations of these terms. And then we did a thematic analysis as well to understand the nuances and differences in measurement. So these are our Prisma results, and you can see from the numbers that we started with almost 18,000 articles, and then eventually ended up with 159 articles in total. So what we found is that, surprisingly, actually, I was really hoping we'd get some clarity from this review, but what we found was that there really is limited consensus on the definitions of team collaboration, functioning, performance, and effectiveness in interprofessional primary care. We found, surprisingly, a lot of times that these definitions are not even provided in the literature, which makes it even more confusing. And then when they are used, there's various usages. People interpret these different definitions differently. And then finally, we also found that there was interconnectedness between the terms. So sometimes team functioning was the output of team collaboration, and other times these terms are used interchangeably. So same thing with team functioning and team collaboration. And surprisingly, a lot of the literature really focuses on team collaboration in primary care. So what we did is we then looked at the explicit definitions that were available in the literature, and we tried to tease out what the definitions were. So for collaboration, we found that there were 5 kind of key concepts coming out. That it's a relationship, partnership, interaction-focused process that blends team members' complementary competencies and skills, provides a mechanism of communication and shared decision-making with the aim of achieving common goals and shared objectives. So that was more commonly understood in the literature. Team functioning was sometimes very similar to this definition. Other times it included the notion that the team has the competency and the ability to acquire and integrate these skills, and sometimes it was the outcome of collaboration. Team effectiveness and performance are actually less well defined in the literature because there isn't that many studies, but what we found was that sometimes it was a process, so it could be team collaboration and functioning, and sometimes it was an output, so system performance types of outcomes. or it was both. In terms of the data sources, so the results here are just for the concept of collaboration. We found there's commonly 4 different ways of collecting data on these different concepts, survey instruments being the most common. Qualitative data sources included interviews, focus groups, observations, document reviews. Then there was EMR data sources as well as administrative data sources. What I really want you to see from this is that just for that team collaboration concept, there was 27 different survey instruments. So like, which one do you use, right? And then this slide is very interesting. So I've only highlighted for you sort of the top 10 here. There's like 100 that we pulled out. So we essentially looked at all of the different domains for these concepts. So for example, communication, roles, team support, team member knowledge and skills, conflict management, shared goals, accountability, patient-focused care, leadership, and coordination. And you'll see that there's overlap in all of these indicators across all of these concepts, right? So again, to show that there's really a lack of conceptual clarity because all of these domains or indicators are within these concepts. And then on this slide, I've just identified what were the most common indicators or domains that we saw in the literature in relation to these different concepts. And then what we did next is we decided to look at different instruments, just as an example, to see if we're looking at these 28 or 27 instruments, you know, are they saying the same thing? And what was interesting is that some of the indicators in them are quite different. So for example, the attitudes towards collaboration instrument looks at professional communication between myself and the GP is open and honest. That is an individual interaction that is being measured in that tool. But when you look at the team climate inventory, there's questions around we keep in touch with each other as a team, or people keep each other informed about work-related issues in the team. So here the concept is more about looking at the team. So you can see that there's various nuances even within the survey instruments. And then we teased that same thing out for the 3 other domains and found very similar nuances. So again, this is really to demonstrate, again, just the lack of conceptual clarity that we have when it comes to this terminology. So what we've concluded from this work is that, you know, we really don't have clarity on these terms. And, you know, how are you supposed to measure something if you don't know how to define it? So our next step really is to look at developing a consensus-based definition for these concepts, recognizing what are the measures and indicators that we need to be looking at, and potentially creating a new instrument for primary care. And here, in my view, this needs to be done in consensus-based manner, right? It has to be done with the professionals and different stakeholders so that we can actually get people to participate in it and adopt it as part of the performance measurement frameworks. So that's the end of my presentation. Do you have any questions? Anna, go ahead. Thank you.
Hello, does this work? Yeah. Thanks, Monica. I'm wondering what that could look like. Is this like a summit that we host and then every kind of, you know, stakeholder, interested party comes to the table with their idea of what that would look like? Or is it by association and then every association decides what they think about it? Or how do you see this happening?
Yeah, so what I see is sort of a Delphi approach, right? So we've done that work up front, which took us a year, right? It was a lot of work. We've essentially identified all of the different things that you can look at, right? There's at least 100. So for me, to build consensus, I would identify who are the important people who need to give us feedback, create a Delphi survey and go through multiple rounds so that we can at least get to some minimum data set, right? The other thing is this needs to also be informed by the evidence, right? What is a high-functioning team, right? What is the evidence telling us about a high-functioning team? And having reviewed 136 articles, we actually have pretty good evidence now on what is a high-functioning team. So we also need to use that to guide the metrics and the development of the instruments.
Is this on? Yeah. Thank you. That was a really interesting presentation. And I can see how it would be so important, as we've been talking about this morning, the importance of teams and how teams can increase or support primary care attachment. Perhaps I missed it at the beginning. You had the 4 concepts, and then you had the different ways, the different domains that were all included in those. How did you choose those original 4 concepts from that large list of like the different ways you could have categorized this work?
Yeah, so actually the concepts came out of our initial review, which we published, and it was really about looking at intrinsic, extrinsic motivators in team-based care. And that's when I realized in looking at this literature that these concepts were not being defined. And so we teased out from that original review what were the common concepts that were arising where we couldn't figure out what the real definitions were. So we use those 4 because those are the most commonly used in the primary care literature. Okay, I think I'm at time, so I will introduce our next speaker. So Hina Ansari from St. Michael's will be presenting on aligning investment with need, an assessment of Ontario's expansion of interprofessional primary care teams.
Hi everyone, Hina Ansari. Thank you all very much for being here today. And thank you to the organizers for this opportunity to share a little bit about our ongoing evaluation of interprofessional primary care teams and their alignment with need. So before I start, just want to acknowledge our funders who made this work possible. In addition to what's on the slide, I also want to acknowledge the health system, the CIHR Health System Impact Fellowship Program, through which I was funded at the time of initiating this work. So a little bit on the background, not too much. We've heard this story this morning. Access to primary care continues to be a challenge across Canada. Ontario, like several other jurisdictions, has been trying to address this in several ways, and one of these ways is by expanding team-based models of care. In April of 2024, the province announced a $90 million investment to create 78 new or expanded primary care teams, which could include any of family health teams, community health centers, nurse practitioner-led clinics, as well as Indigenous primary health care organizations. Since then, there have been many funding announcements, each with slightly different goals and criteria. However, it's the first round of funding that we are looking at in this evaluation, and that's the focus of this study. And the aim of this first round of funding was to improve access and attachment to primary care, especially in high-need communities. Before evaluating whether the teams achieved that goal, it's important to look at who got funded in the first place and whether and how the direction of investments aligned with need across the province. So we set out to examine exactly that, whether the direction of the initial 2024 investments aligned with the intended goal of enhancing access to primary care, particularly in high-need communities. We had 2 objectives specifically. First, to describe the new teams compared to existing teams on their patients that they serve. And secondly, a more area-level focus to examine how the new investments were distributed relative to areas with high levels of unattachment and multimorbidity. So we conducted a cross-sectional study leveraging administrative data at ICS. Due to our own data limitations, we were not able to include nurse practitioner-led clinics or Indigenous primary healthcare organizations. Our patient level analyses stratified by model of care. So patients of newly funded FITs were compared to patients of existing FITs, and patients of newly funded CHCs compared to patients of existing CHCs. Our index date was April 1st, 2024. This is when successful applicants were announced and funding was initiated. So the patient level comparisons that we're talking about here are existing patients at these teams and not new patients enrolled as a result of the funding. The covariates that we looked at captured key demographic factors, health status, and we also looked at health service utilization and quality of care. To address our second objective, we carried out area level mapping, plotted new investment locations against area level measures of attachment and morbidity. There are different ways of measuring attachment, as we heard in the morning, and the methodology that we used is based on a previously published validated algorithm. So on to results, starting with our patient level analysis. So what we found is, with respect to the several characteristics that we were able to measure, our data suggests that clients of newly funded CHCs were more likely to be from marginalized neighborhoods and sicker in many ways than clients of other CHCs who were not selected for new investments. For family health teams, our data suggests that patients of newly funded family health teams were more likely to be from neighborhoods with higher material marginalization, but also less likely to be from neighborhoods with racialized or newcomer populations. So onto our area level work. This is a dot density map, and I'll walk you through it, illustrating new and existing investments in FITs and CHCs relative to the number of individuals uncertainly attached to primary care. So each black dot there represents 100 uncertainly attached individuals. In the yellow, you have all the FITs and CHCs across Ontario, and in the red, those that received new investments. So I'll direct your attention to the clusters that you see, which is clusters of uncertainly attached individuals. And we also see many new investments directed to many of those clusters. We looked at unattached numbers in a slightly different way. We plotted the number of new investments relative to FSA level unattachment. So on the vertical axis, you have FSAs ordered into deciles based on the number of uncertainly attached individuals, and stacked against the number of new investments belonging to each decile. So moving from the bottom to the top, there's a general increase in the number of investments in FSAs with a higher number of uncertainly attached people. A slightly different look at unattachment. This is unattached proportion. So we're looking at new and existing investments relative to the proportion of uncertainly attached individuals, with the darker shades representing a higher proportion. And what we see is, again, some areas that have a much higher proportion of uncertainly attached that receive new funding, but then there are other areas on the map with a similar proportion of uncertainly attached individuals that did not. We also looked at morbidity using the SAMI score, and you have, again, areas with more complex multimorbid patient populations across the province. Some of these areas received funding in 2024 for FITs and CHCs, while others did not. Notably, there were also some high-need neighborhoods that did not have any new or existing investments in FITs or CHCs. So just to summarize our key findings, at the patient level, our analysis suggests that recent investments have been directed to organizations that serve sicker and more marginalized populations compared to other teams, although it remains unclear how much existing patients will benefit from the new funding. At the area level, investments were generally directed to areas with higher densities of unattached individuals, and the number of new investments tended to increase in areas with higher numbers, but not necessarily a higher proportion of uncertainty attached. There were some areas with more complex patient populations that received new funding, and others with similar or greater need that did not. And there were also high-need neighborhoods that did not have any new or existing investments. Taken together, the study suggests that investments were broadly targeted toward high-need patients and communities, but there are opportunities to further address unmet needs and close more gaps in future funding rounds. And the fact that there are gaps is not a surprise. Ontario has long-standing disparities in access to team-based primary care, both in terms of the geographic distribution as well as the populations who are able to access it. And this has been demonstrated through previous research, and we also saw that in some of the maps, and it only underscores the need for continued action and more targeted investments. The different models of team-based care also reach different patient populations, which is one of the reasons that we chose to stratify our patient-level work. And we had some interesting findings that would have been masked if we had pooled both the models together. At the area level, we looked at unattachment and morbidity, which are just two measures of need, although need can be defined in many ways, and how the different measures are prioritized, whether it's unattached numbers, unattached percentages, whether it's morbidity. These decisions have implications for closing the equity gap in access to team-based care. Our next steps include evaluating the impact of these investments on quality of care and outcomes for both new and existing patients. We also did not examine how the investments are being used within the organizations, who was hired, which health professionals were hired, and whether they will serve the needs of the community, but that's an area that requires further work. And aside from need, there are obviously several other organizational level factors like readiness to implement that will impact funding decisions. Sorry, I think I didn't advance that slide, but just wrapping up, a couple limitations that I will point out is that we were not able to include nurse practitioner-led clinics and Indigenous primary healthcare organizations, although FITS and CHCs have historically been the two most dominant team-based care models in Ontario. And so our maps are slightly conservative in that they don't represent the full spread of team-based care across the province. We also did not take into account satellite locations of some of these organizations. So we have what we have illustrated on the map are main locations. So slightly our results in terms of alignment with need are slightly more conservative. And with that, I'm open to questions.
Thank you, Insa. Great presentation. Any questions? Okay, well, I'll start with one. One of the findings that I found striking was the one about racialized communities not being represented in the FIT model. Do you have any sense of why that might be the case and how we might address that?
Yeah, I think it's interesting. We've seen this historically that we have differences in who is served by CHCs versus FITs, and CHCs historically have been able to serve or are mandated to serve more newcomer and marginalized populations, whereas that's not necessarily the case for family health teams. I don't have a direct answer to your question about how we could change that, but I think it does have implications for how we decide on who gets funded and whether and what our goal is, whether the goal is to have equity in access or something else.
Thank you. Okay, I think we have time for one more question.
Yeah, hi, Steve Nastos. I work with the OMA. Looking at the maps, I'm always reminded of the vast north, the geographic disparity that occurs in northern Ontario. And I was wondering about, you look at the dot density, you see where they fit. Makes sense in more populated areas. In the north, it's a little bit more sparse. I'm wondering if distance factored into any of the analysis, like distance time to accessing care, or how far population is compared to the FIT center or the new EOI that was announced.
Yeah, we didn't look at that in our study, but that's a great point, and I don't know if Archana is in the room, but Archana Gupta has done some work looking at distance and how that factors in to access, but we didn't specifically look at distance here.
Great, thank you.
Thank you. Okay, so on to our next presentation. This will be by Cathy Hurst from Ontario Health, and she will be presenting her study on profiling primary care teams, linking size, composition, and capacity.
Thanks, everyone. I'm really excited to be here today. As you know, I'm Cathy Hurst. I'm a registered nurse by clinical background, and I'm also the manager for Interprofessional Primary Care Team Expansion. So that stuff Dr. Philpott was talking about earlier, the implementation side of that. Today, I'm presenting on behalf of myself and Dr. Anna Chavlovsky, a family physician and the primary care clinical co-lead for East Region. And just as a thank you to Ontario Health for providing the data, and a reminder that the findings are the authors only, and it doesn't represent the views of Ontario Health necessarily. Can I go to the next slide? Thank you. Oh, I have the button, don't I? My bad. I'd also like to acknowledge that I'm a Tutor Primary Healthcare Fellow, so thank you to Tutor, PHC, Inspire, and the Ontario Sports Support Unit for supporting this analysis as well. So, sorry, I'm a prof, so I like to walk around while I talk. So understanding capacity is kind of key to supporting attachment. So as you're aware from Dr. Philpott and probably many news articles, the focus in Ontario right now is on attaching 100% of patients to primary care by 2029. I think a kind of essential matter that we need to address to do that is understanding capacity. So you can see here that the Oxford Dictionary defines capacity as the maximum amount that something can produce or contain. I wanted to understand this a little bit more in the context of primary care teams specifically, so I completed a scoping review to understand how capacity is defined and measured in primary care. And what the literature showed was that we currently define it using quantitative measures. Things like panel size, visit volume were commonly cited, but there's a lot of things that are missing from that. And if you saw my poster, there's a whole little iceberg graphic that goes into it in a little bit more detail. But one of the key things that I'm going to focus on today in this descriptive analysis kind of tries to look at is team function and role contribution. So how different team members in an interprofessional primary care team contribute to capacity. So contribute to that panel size, that visit volume, and all these other factors that we see kind of grayed out for the purposes of this presentation. So to do this, we analyzed administrative and HR data from 34 family health teams in Eastern Ontario. Our goal was actually to understand how the teams were composed, so who was on them, and how those structures might relate to attachment capacity, so the panel sizes of the physicians or nurse practitioners that were in the most responsible provider roles. After cleaning the data and excluding any incomplete reports, we focused on three main elements of the data. That was the actual members of the team, the actual full-time equivalents on the team, as well as the overall team total panel size or enrollment number, or whatever term you prefer to use. There were 3 key outputs from looking at these specific things. One of them was a team sizing methodology. The next one was an adaptive profiles, looking at different team sizes and how they're composed, bringing out things like anchor roles and bridge roles, which I'll get into in a minute. And then there was a kind of theory proposing a typology of interprofessional healthcare providers and how they contribute to different types of capacity. So this first output, the team sizing methodology, was very much out of necessity, taking data from multiple teams, even across the same model. I think a lot of people have alluded to this already. It's very difficult to compare them because they're so different. There's so much variation. So we classified teams by size using a consensus-based approach across 3 measures. So you can see them in the little circle. The most responsible provider, FTEs, or estimated FTEs, same limitations as Dr. Karen noted earlier in terms of actually having those for our MRPs, and total clinical team FTEs, as well as the total panel size. Looking across all 3 of these, we were able to classify teams, as you see here, in small, medium, or large categories based on these different parameters. And this was how they naturally presented. You'll also note that we didn't include administrative data, but I do include it in this graph here. That's not because I don't think admins are important. I actually started as an admin in a family health organization, and I think they're extremely important, but they were so varied that it was really hard to use them as a measure in the methodology at this time. So when we took the team sizes that were developed and we compared them to the estimated MRP attachment capacity, so that team panel size divided across the number of MRPs, recognizing that's not exactly how panels work, but just to see like what would it be like if they all kind of took the same number, like they had a target that was all the same, for example. We saw that large teams had, of course, more professionals on the team. They had more MRPs, they had more interprofessionals, but they actually didn't have a higher panel size per MRP. So they actually distributed that larger total panel across a higher number of people, but that didn't mean that the team attached more people per physician or per nurse practitioner. We also saw that small teams, by contrast, actually had the highest per MRP capacity, or estimated per MRP capacity, of up to 2,000 patients in several examples. So they had a smaller total size, they had less professionals, they had less MRPs, but they seemed to actually have more capacity to attach patients to an individual physician or nurse practitioner. However, that could indicate functional efficiency, like I've just kind of described. You know, they're smaller. We know in team science that small teams have better communication. They generally function a little bit better, at least to start, and without much help or as much help. But it can also indicate that they have higher workloads that are not being supported in the same way that a medium or large team are. Obviously, we need further validation to confirm those findings or to interpret them a little bit more. Medium teams were super consistent. The panel sizes that we saw were actually pretty similar across all the medium teams sampled, while large ones varied significantly. So this suggests that capacity emerges from interactions, not just from the number of professionals on a team. I'm going to use complex adaptive system a lot here, so that's kind of a key factor in complex adaptive systems. Another interesting finding, if you look at the graph on the left of the admin capacity, is that small teams actually had higher per MRP admin support than the large teams, which you can see like the inverse scale there. As teams get bigger, their per MRP admin support actually decreases instead of increasing as we increase MRPs and patients. The second finding here is the adaptive profiles, or what we're calling adaptive profiles. This is kind of what the teams looked like in the different sizes. So you can see here that the small, medium, and large teams generally had, medium and large look actually very similar, but you can see the ranges are slightly different as per the previous graph. A key observation is that large teams were varied. So you can see here that their range of patients goes from 10,000 to 60,000. So this suggests that some teams medium, or large were either under or over-resourced, or that there's teams that are serving complex patients requiring more resources but serving a lower panel size that we're not like accurately seeing just from this kind of analysis. We also saw big differences in administrative support. If you look at the small team, it's like kind of an expected range. Medium and large, huge range in administrative support. Some large teams had as little as 2 FTE administrative support for their whole family health team, despite having 35, for example, FTEs of clinical staff. This once again suggests that capacity isn't simply about the number of staff, because if we think back to the graph I showed before, we saw that large teams had lower per MRP capacity. They also have lower per MRP admin support, and we're seeing that some teams are not resourced in the same way for admin support. So how teams are structured, supported, their functional design essentially really shapes what they can achieve in terms of attachment, or it seems to from the appearance of this descriptive analysis. This is just another kind of way to illustrate that. So you can see the other finding from the adaptive profiles is anchor roles, which we're kind of referring to as stable roles that were present across 75% of the family health teams sampled. So you can see that in addition to your MD and NP, you have an RN, you have a registered dietitian, and you have a social worker holding a master's degree. Those were present in 75% of teams, at least, across contexts. So across sizes, and you'll notice a couple other contextual factors there as well. And then on the right, you can see the RPN pharmacists. Those were considered bridge roles. They're more fluctuant. They depended more on the context. So you can see there that there was no pharmacists in any of the small teams sampled, but there was a high number and consistent use of a pharmacist in large teams. And then they varied across different contexts. So again, something that requires further validation and exploration to interpret. But the variability in the team members reflects self-organization, which is also a complex adaptive systems theory concept. Teams adapt their team composition to meet local needs and available resources. That's what this suggests. And then finally, the last kind of output is just an emerging theory of typology of interprofessional healthcare providers and how they might contribute to attachment capacity differently. So from all this analysis, it's noted that, there doesn't seem to be a consistent team composition across any of the fits that we sampled that contributed to attachment capacity in the same way. So there was no increase based on like a certain composition. We didn't see that. What we did see is that some roles may be more present in teams with higher per MRP attachment capacity, such as registered nurses. So the suggestion is that there's some roles that are functional capacity expanders, which may increase direct clinical capacity to attach in a more immediate sense. And then there's adaptive capacity expanders who may strengthen prevention, like things like population health and the team's longer term resilience. And they do contribute to capacity to attach, but it would be over time. So you have eventually healthier patients who don't need to come in as more, and then you have more space to take on patients. All this to say that all roles are extremely valuable in a team, but their contributions may shift depending on the team context. That's what we observed. A nurse might expand functional capacity in one team, adaptive capacity in another. They may do both, depending completely on how the team is organized and what their actual role description is. That flexibility, though, is what makes teams effective in complex systems like primary care. Capacity doesn't come from one single role. It emerges from how roles interact, adapt, and respond to local context. So this is just an illustration of that exact concept of complex adaptive systems, a network of connected roles and relationships, as I've described, the anchor roles in the center, around them the bridge roles, surrounding them are external system factors that impact how teams work, how they function, even when they're outside of their direct context. So together, this demonstrates a key complex adaptive systems theory principle that capacity emerges from interaction and not just the composition of the team. So planning can't focus on how many people are in a team, or it shouldn't just focus on how many or who, but rather how we work together as a team, how roles connect, how information flows, and how teams adapt to different contexts. So looking ahead, we're going to continue, hopefully, to do this work at a provincial level and look across team models. FITs were just the easiest kind of data available at this time. We also want to explore administrative roles a little bit more deeply, given the trends that we're seeing there, and understand their impact on coordination, team function, and efficiency. But the key takeaway, I think, is the value of flexibility. Teams with similar core roles showed variation in capacity. Like I said, there was no single composition that had higher capacity. The context really mattered, and that's what affected it. Highlighting that how teams are organized and adapt matters more than their exact composition from what we can see from this analysis. Practical supports like coaching, like workflow guidance, role clarification can strengthen team function, while adaptive approaches help teams to operate effectively within their unique context. Importantly, these findings need to be validated with teams, with planners, with patients as well, to see how they define teams and how that fits into this whole concept. And that validation can be used to inform adaptive planning tools. Things designed to guide resource allocation, team design based on real-world capacity and complexity. In short, capacity in primary care doesn't exist as a fixed number. It's something that emerges from relationships, organization, and adaptability, and supporting those dynamics may be the most effective way to strengthen care across the system. Thank you.
Thank you, Katie, for that insightful presentation. Really well done. We don't have much time left, but I'll just provide one person with the opportunity for a question.
Thank you, Kate. Could you just confirm I'm understanding one aspect correctly, that it seemed like the team composition, there was no specific IHP component that drove panel sizes, but it did seem to, from what I was understanding, that administrative support, so the smaller teams had bigger panel sizes, but had a better, more favorable ratio of admin support to the clinicians.
Yeah, that's exactly what we saw in the data. Now, the anchor roles were consistent across like a large majority of teams, but it's not clear that it's because of who they are necessarily. Because of the different contexts, we saw their fluctuations, things like HR constraints and other things I'm sure affecting that. But the administrative was very, very clear that as like the panel size was higher in the small teams and lower in the large teams, and that was the opposite scale for the administrative support.
Thank you, Katie. Great presentation. Okay, so next up is Cathy Risdon from McMaster University, and she will be presenting on the Greater Hamilton Primary Care Atlas. Welcome.
Do you guys turn this on or do I turn it on? No? Ah, voila. Hello, everyone. Nice to see you. Thanks for hanging in the postprandial hour of a really stimulating conference. My name is Cathy Risdon. I'm the chair of the Department of Family Medicine at McMaster, and I've been really involved in the evolution of our primary care network, which actually began before OHTs were announced. So we have the privilege of working in a system in Hamilton that was trying to do some collaboration and mapping adjacencies for some years. We have a long way to go, but I'm grateful for a culture in Hamilton of working together. And a really critical partnership for the last 5 years has been with the Department of Public Health. Our academic department is co-located in the building with Public Health, a familiar model to some of you, but it was a real addition to our ability to think about our work in Hamilton. So I'm shouting out colleagues from Public Health who were involved in the creation of this resource, and really advocating for the key role public health is playing as we design a primary care system that's going to work for the whole population. And I need the clicker. There we go. So the background is familiar to all of us. A mission to bring the voice of primary care into health system planning, understand the settings in which we are doing planning, and really look at equity issues and optimize available resources, attending to the primary care practice environment. So these functions are guiding lights for all of us, and they're all invitations to different forms of engagement. Again, this is our ultimate goal, is connecting every person in Ontario to primary care. So to be in an environment where a primary care network is emerging, that sense of pan-sector engagement is taking shape, and you know, some of what we've already been talking about is how do we know we're all talking about the same thing when we're talking about this thing? So I think this atlas was a really important strategy to achieve a lot of those aims. So let me tell you more. Again, the puzzle we're all solving is looking at our context and figuring out how we can get everyone attached to a primary care home. And there's so much implicit and explicit assumptions, cultures, backstories, and then to move those into prioritizations or shared visions is a real social challenge. And I appreciate the method Kate was alluding to, because this is an intensely social process of calibrating common knowledge and what we think we know. So our team realized we had to get really specific about that for the population of Hamilton. There's about 600,000 people in our municipal area, and we also have responsibility for Haldimand, Norfolk, and for West Lincoln, Grimsby area. So a very diverse population. Again, with our own mix of humans and resources. How do we make sense of what these all mean, and where we're going to focus attention in the movement towards full attachment? So the three key players in forming the Atlas, as I say, the Department of Public Health, the Academic Department of Family Medicine, who can bring some of the familiarity with research methodologies, formulate questions to ask various data sources that relate to primary care, and of course the Primary Care Network, who is the container for the broadest stakeholder engagement that we can do in this work. And as I say, we've had the benefit of co-locating with public health. So I can't tell you how many random strategy meetings occur in the hallway between the shared washroom space and the pathway back to our offices. There is nothing like co-location. I'm so glad we're all here together today. So the Atlas started for real in the fall of 2024. We held what we called a data jam, which was anyone in Hamilton who wants to sit around a table, get some literacy about sources of data, and start talking through the assumptions that shape data, how it's made, and how it might help us. We sat in a room. It was a fabulous group of different health disciplines, administrators, patients, epidemiologists, and it was just fun to, again, talk through what it is we thought, what story we thought we could tell by bringing everyone's data and expertise together. So we came to consensus as a network on the data points we wanted. And then, again, the beauty of a collaboration with public health is we could submit a ICES-applied research question using our public health colleagues who have slightly less fettered access to data in the service of public health than we might have as a academic department. So that was a great part of the collaboration. And the public health expertise in GIS systems and the geomapping, of course, was really critical in moving these data points from like a two-dimensional page into a geographic concept of this place that we are planning for and serving. So I'll tell you a bit more about how that resource then has really started to inform not just our shared understanding, but also our strategic requests for funding and for investments in the community. So we have 6,000 data points in the Atlas, and the three main sources of data have been the population health data that public health brought into the Atlas. They had done a really extensive school health mapping project for the region, and all of that really described the needs of the population who were school-aged. And so being able to import that in the Atlas was great because they'd done a lot of that background work already. and the social determinants of health data, of course, closely related to that. Now, we also had, we've had a 20-year history of a physician recruiter in Hamilton, and thanks to the workflow that person carried, they actually had like a little black book that knew each provider and a bit about them. So the data about where primary care was actually planted in our region was extremely accurate, and I know figuring out where physicians are has been a surprisingly weird challenge to this. So we actually had a little black book that we could plot into the atlas. And then we could also characterize the multimorbidity and the unmet health needs of people, who is using emergency room for ambulatory sensitive conditions. Pulling in data from there was also really helpful. So this is a screenshot of sort of the landing page that we often use for the atlas. It again uses the GIS template that Public Health has supporting their work, and that is a public-facing, the Public Health GIS system is public-facing. Our atlas is planner-facing, but actually the addition of all of the primary care physician and doctor's offices have made this a slightly contentious resource that we don't really think we can just put on a public URL. And we actually know that the physician data is available on the CPSO website, but it's not extracted in a form that anyone could just map physicians' offices, right? So we used our black book, we verified with CPSO, we've not done anything nefarious or privacy violating, but we actually know there's a sensitivity for physicians' offices being publicly mapped. I hope somehow that just happens province-wide and we don't have to worry about that sensibility, but it's still an issue, and so we have a light restriction to being able to access the data. Maybe just to interpret what you're seeing right now, the darker the blue, the higher the rates of unattachment. If you know Hamilton, that really dark blue area is the lower Hamilton City region, which has been perennially underserved for many, many years. And then we have some larger rural-ish areas that also had some unattachment. But the beauty of the GIS system is we can really drill up and drill down. So here's a single building block of the blocks that Public Health uses to build out the whole map. And this is a much smaller area. If you can see, it's a 12-minute walk from one end to the other. And this is a high intensity block within the city of Hamilton. I'm sure folks from Toronto recognize many of these types of blocks of non-attachment, high levels of morbidity, multimorbidity, social deprivation, transient housing, et cetera, et cetera. So even if we could sort of solve the attachment and primary health care problems for this 5-city block area in downtown Hamilton, we will have achieved some pretty substantial outcomes in terms of excess healthcare utilization, crappy life outcomes, ED use, et cetera. I'll have to say that when news of geographic attachment, for a while there was that description that said, well, let's just see where all the family doctors are, carve out their neighborhood and make them responsible for all the patients. That would terrify the practice that's closest to this block. So, again, understanding then what the true distribution of need and resource is, I think is a really helpful strategy in moving forward with the work. The Atlas came in very handy when that first call from proposals came out last April. It was nice to hear Jane's backstory and why a postal code was chosen. The postal code chosen for our primary care network is the largest geographic postal code in Ontario. It's larger than the size of Toronto. So no surprise they had a high number of unattached patients across a very vast geography. And if we had not had the atlas, it would have been almost impossible to know how to start drilling down on who to even talk to start a collaboration, to put in a proposal. So this was very handy to to take, you can see the area in red was the part that we had to start planning for. 3 disparate areas is the other weird thing about postal codes. They're not even contiguous in all cases. But we could at least take that really impossibly large area, look at the smaller building block chunks, and start thinking about who we could approach and what the needs in the sub-regions of that area are. So we could do a more refined assessment. We knew where the docks were, and so we went to all the practices in that area to see where there might be some possibilities for partnership. So we were saved a bit by this for call 1. In call 2, you can see I've outlined what the forward sortation areas are. If they had just taken each postal code area, it would have obscured the non-attachment in our downtown, because our downtown had 4 forward sortation areas. The atlas allows us to carve out an area, and we've carved out one in red that we're prioritizing for our attachment work downtown. Again, we can play with the postal codes if we need to, but we can also name a sub-region within that has relevance. So just a few lessons learned. Leveraging local data has been really important, and I think everyone's telling stories of that in different ways. The local expertise has been a real gift, and I would say the relationships we formed as we did this journey of co-creation is the most priceless resource of all. So we have now a common language, we have a shared vision, we have a shared understanding, and we have, I think, a heightened appreciation for the expertise. And I think it's not, public health has been a strong partner, but I think they're actually even more present now because there's been a mutual recognition of what we're all bringing to the table in this project. So, takeaway message, the shared vision for primary care requires data, it requires expertise, and the trusting relationship between partners. Data builds the map, but for us, relationships really charted the journey.
Thanks, Cathy. Thanks, Cathy. I had the privilege of watching this presentation before. I think this is a great initiative. Does anybody have any questions about it? We have time for 2 questions, maybe.
Thanks, Cathy. This was such a great initiative, and I love the take-home message. I was wondering how you plan to keep the physician census up to date.
So I think actually our physician recruiter is in a really good place to do that. And there's a network of physician recruiters in Niagara and Hamilton, very strong. And they have some good orientation packages. And like anyone sort of coming into the neighborhood is immediately referred to the recruiter. So some of the new practices and new people coming in are through the recruiter, but actually the network now of anyone practicing knows to link that person, because that's often the person that helps them join the PCN if they're new to the community. For retirements, about 60% of our patients are cared for by the 2 family health teams, with another 10% probably by CHCs and so on. So there is we have a bit of a blind spot for the unaffiliated group. So really, I think our efforts to keep engagement around the PCN is to make sure we can also keep track of them. And every time we hear of something to do with the physician, we make sure that the little black book gets updated. So it's not perfect, but I think it's pretty darn good for what we need it to be.
Okay, thank you. So that closes our session. Thank you very much for coming, and thank you to the presenters. All great presentations.